Greater New York Dental Meeting is the largest dental meeting in the United States.
For this implant, we have to do like gingival sculpting. So again, we send it to a periodontist.
This is day 4 of my personal participating on the event, and day 5 on the greatest New York dental meeting. It's all about the same every day. Today it was another lecture about endodontics. I worked in. The speaker were talking about endophiles, the simple access and the possibilities how to manage the root canals, all the same. And there were a little less people than on Sunday, and on Monday I worked, so I didn't come in here yesterday. Right now I'm headed to Dent Supply SR1, and they're giving out the free samples of Wave 1 files for only those participants who listen to the lecture I just came from.
You use larger files, because I'm more aggressive with it, because you just get more comfortable. I don't overdo it. The thing is,
So right now we're at the lecture of my friend Dr. Amey, whom you've seen in the other vlog, in the previous vlog on this channel. We're just checking the room.
See you later. Hey guys, how are you?
Thank
Come
you.
on in. Thank you. Good morning.
Good afternoon, everyone. I'm Dr. Amey Patil, currently working as a faculty at Rutgers School of Dental Medicine. And I did my dentistry in India, Mumbai, and I came here in the United States in 2013. I completed my fellowship in aesthetic and cosmetic dentistry from NYU. And I'm presenting the lecture on TMJ Disorders and Smile design. So this is Mumbai. I was born and raised in Mumbai, which is the hub of Bollywood stars. And now here I am in New York. So according to RDC TMD, Research Diagnostic Criteria for Temporomandibular Disorders, there are only two main muscles, major muscles. Those are like temporalis and masseter. So if you're having pain in temporalis or masseter, you have to palpate these muscles, and you will come to the diagnosis what exactly it is, myalgia or myofascial pain or myofascial pain with referral. So for that, they mentioned that there are 3 zones in each muscle: anterior, middle, and posterior zone in temporalis, and origin, body, and insertion. These 3 zones in masseter muscle. How hard you have to palpate? So while palpating, you have to give 1 kilogram pressure on each zone. So these small green signals, green circles, which denotes a fingertip. So how to calibrate? Your pressure is 1 kilogram. How many of you have handheld algometer in your practice? Very few, right? So nobody. So the thing is, you have to calibrate with your fingertip, and then you can just calibrate like 1 kilogram and then press it towards that particular area of the muscle. While doing this, once you calibrate yourself, you're good. Temporalis palpation, zones of palpation there are 3 zones: posterior, middle, and anterior. As I mentioned, anterior zone, middle zone, and posterior zone. These are masseter zones. For TMJ lateral pole palpation, what you have to do, you don't have to put like 1 kilogram pressure. You have to give like half of it, 0.5 kilogram pressure. That pressure you have to give on the lateral pole. So one finger is used and one joint is palpated at the time, and the other hand is used to stabilize the head of the patient. So mouth will remain closed in this, and then you can you will use like 0.5 kilogram pressure after calibrating yourself with that. For the dynamic TMJ lateral pole palpation, how to do it? Like identify after the mandible is sufficiently protruded in position, protruded position. So once mandible is protruded positions, what you can do? Tell the patient that okay, protrude a little bit. Once that patient is protruded, you have to palpate behind the condyle. But then at that time, you have to use like 1 kilogram pressure. Area palpation, which is not mentioned in RDC TMD criteria to come to the diagnosis. But sometimes patient protrudes and he is having pain, so that is the main thing, because their lateral pterygoids, they are painful. So how to palpate that? It's just a finger placement while mandible is deviated on the same side. Palpate the most medial, superior and the posterior area of the mandible. Then moving to the temporalis tendon palpation, finger placement against the ascending ramus while the mandible is slightly open. And the finger is moved superiorly as far as possible while maintaining contact with the underlying heart surface. Coming to the good diagnosis, you need to know thorough history and good physical examination. After that, you will come to the good diagnosis. Then go for your radiographic examination, or you want to do blood work for the patient or anything. So let's have a look on the diagnostic decision tree. I'll make it simple. There are various treatment options, as you can see here, for myofascial pain, pharmacologic, biobehavioral, physical, occlusal splint and trigger point injections. So initial control of the pain we can treat with the simple analgesics. For widespread pain or poor sleep, comorbid depression, we can use psychotropics, TCAs or benzodiazepines. For presence of muscle spasm, we can give them muscle relaxants. For cognitive behavioral therapy, we can use for medications contraindicated patients, or significant psychological distress if that is present in patients. Relaxation, hypnosis, psychiatric referral, that can be done as a biobehavioral therapy. Laser, stents, these are new techniques which are coming up. There is not enough literature on these techniques, but these are another option for medications, contraindicated patients, or adjunct to physiotherapy. Physiotherapy is a good option. Physiotherapy that helps a lot. There are various papers. According in the literature, it has mentioned that physical therapy is good. So medications, contraindicated patients, we can give physical therapy, or patients who is having limited mouth opening, that helps to come to their active range and passive range of motion, to restore their range of motion. Physical therapy helps a lot. Stabilization splints, which are again good for such patients who are medications contraindicated, or they have regional myofascial pain. That helps. Trigger point injections with local anesthetics or dry needling, that will help and identifiable trigger points. So let's discuss the case. This 62-year-old patient comes to us in our clinic, and with the chief complaint of my teeth become shorter. Can you please make them good? So let's have a look at his smile. This is his smile, and this is the way he smiles. This is his right side profile. This is the occlusal view of maxilla, occlusal view of mandible.
Wow.
And you can see here all treated. Some other dentist, he already did crowns, but the crowns look shorter. Panorex, you can see in panorex missing teeth number 1, 16, 17, 18, 30, 31, 32. Root canal done on number 3, 19, 29. Bridge on 6 to 11. And restoration with 5, 13, 14, 15. So condyles are good. So this is full mouth x-ray of this patient. So this is like MIP, maximum intercuspation right view, MIP left view, MIP frontal view, MIP, this is protrusive right view, protrusive left view, So we give orthotic appliance. This is diagnostic wax up. You can see diagnostic wax up on the cast. Here, these are processed provisionals and processed provisionals in mouth. These are processed provisionals from the right side and left side. Processed provisionals in the patient's mouth. So these are teeth preps. Teeth preps on the right side view. Teeth preps from the left side view. After that, this is a frontal view. And final impression of the maxilla. Final impression of the mandible. You can see implants here, 2 implants on the patient's right side, 2 implants. We did it, we planned it, and then this one later. This is like a cross mounting. We mounted a master cast and provisional cast. This is called cross mounting, which is helpful for labs as well. Casting trine in patient's mouth. Casting trine on the right and left side. This is casting pickup impression. These are final restorations. The final restorations in patient's mouth. You can see the occlusal view of the mandible with this implant. And for this implant, we have to do like gingival sculpting. So again, we send it to a periodontist. So it's like an interdisciplinary approach. CR frontal view, centric relation in again the right side view. CR in left view. It's a frontal protrusive right side, protrusive left side, right lateral protrusive, right lateral protrusive right view, left lateral protrusive frontal view, left lateral protrusive left view, left medial protrusive left view, occlusal view of the maxilla. You can see here, this one was decayed, grossly decayed. We extracted that later, and then occlusal view mandible, PFX, final restorations, and this is patient smile. So give orthotic appliance for this patient later on, and this is the full face of the smile, and this is like a before and after. So you can see how we restored his vertical dimension. So then I was fortunate enough to get his 3-year post-op follow-up, and this is what we can see after 3-year post-op. This is his smile after 3-year post-op. You can see this, the protrusive right side, left side, and occlusal views. And this is his 3-year post-op FMX, and this is his 3-year post-op full smile. So we need to create a very beautiful smile. Beauty is in human face, right? So what we need is aesthetic vision and hand skills. These 2 things are very important. Smile designing, core principles. So let's discuss few core principles of smile designing, which are really important. All dentists, see, for example, with this patient, that patient already went to one dentist, but that dentist, I don't want to say that dentist could he did a bad job. He did a good job, but the thing is, he can do the best job or much better way, like with the help of, if he has this knowledge, anterior aesthetic treatment planning, then definitely he could be better. So for example, if your width is 8 mm and your height is 10 mm, the ratio will equal to 80%. This is like mesial inclination. So like ask your patient and see what exactly he wants. He wants this way, what kind of smile. If he doesn't know, sometimes patient doesn't know what exactly they want, and it's your call. So then you have to look for your patients, his teeth are angled properly. Each upper tooth visible to the smile should have slight inclination to the or tilt that is toward the midline or mesial of the mouth. And if these all imaginary lines are these lines were extended downwards, they would meet or converge at the near the navel point over the stomach. Look for that. Then the third one is medial placement. Your patient's smile is centered at your face. If there is midline is there or no. Gum line symmetry is necessary.
Well, My name is Dr. Mark Gaynor. I'm General Chairman of the Greater New York Dental Meeting. The Greater New York Dental Meeting is the largest dental meeting in the United States. So far this year, we have 52,600 attendees, almost 19,000 dentists, of which 8,000 attendees, actually more than 8,000 attendees, are international attendees from over 151 countries and all 50 states. We have more than 400 educational programs that we offer in 6 languages. And we have a very large exhibition booth. It's the largest exhibition booth in the area in the United States. As I mentioned, we have 1,700 exhibition booths and 700 companies represented. For students that are coming, international students, they are welcome to attend our lectures for free. So they can come to the Greater New York and attend our lectures. If we get actually where you're from, the schools that you're from, we would register you for free and allow you to attend our lectures for free. So we would love to have you. If you'd like to come to our 2018 meeting, we're looking forward to having a number of new programs at that meeting, including a pedodontic summit, including a global orthodontic conference, our World Implant Expo program, and these are multiple day programs. So you have a lot to choose from. So we're hoping you'll come. And I should also include that we're doing a digital dentistry series as well next year. So I hope you'll consider coming to our meeting.